Hi, my name is John Mite, and I'm going to talk about complex simplicity and Hirschsprung disease. The Hirschsprung disease is a motor disorder of the colon caused by the failure of nether crest cells to migrate completely during intestinal development. The resulting ganglionic segment of the colon fails to relax, causing a functional obstruction. In the majority of the patients, the disorder affects a short segment of the distant colon and rectum, with a transition zone in the rectosigmoid. In other patients, the ganglionosis involves longer segment of the colon. In rare cases, the entire colon and parts of the small bowel may also be involved. The disease occurs in approximately 1 in 5,000 live births with an overall male-female ratio of 3:1 to 4:1. When the entire colon is involved, the sex ratio more nearly approaches 1:1.
Hirschsprung's disease is a condition that primarily affects the large intestine or colon. It is a condition that involves what we call ganglion cells, or the cells or nerves that allow the colon to relax. And so the stool is getting backed up behind the segment of colon that is not relaxing. What are the signs and symptoms of a patient that might have Hirschsprung's disease? The first thing that we look for is the failure to pass stool or meconium in the first 24 to 48 hours of life. Often these patients also present with abdominal distension and potentially also vomiting.
Okay. The application in medicine and the management, the disease is suspect based on clinical features, usually supported by contrast enema or anorectal manometry. The diagnosis is established by rectal biopsy. The absence of ganglia on the suction biopsy confirms the diagnosis of Hirschsprung disease, provides that the sample is adequate, meaning that the biopsy were obtained from the correct site and contain at least a small amount of muscular mucosa. If ganglia are seen in appropriately performed suction biopsy, this disease is virtually excluded. The mainstay of treatment is the surgery, the surgical correction.
Children born with Hirschsprung disease often suffer from enterocolitis. The best method for treating this condition is by flushing and emptying the colon with fluid, which is called rectal irrigation. You'll need the following supplies in order to perform a rectal irrigation: 2 small basins, a 60 milliliter syringe with catheter tip, and a silicone catheter. If your child is under 1 year old, a size 16 French Foley catheter should be used. And if your child is over 1 year old, then you'll need to use a size 24 French Foley catheter. You'll also need water-soluble lubricant and normal saline. Start by warming the normal saline. We recommend sitting the bottle in a sink of warm water, then testing the temperature of the saline on your wrist to make sure it isn't too hot. Pour the warm saline into a small basin, then draw up 10 to 20 milliliters using your catheter tip syringe. Position your child so they are laying on their back with their knees bent to their chest, or if they are bigger, with their knees bent with feet flat on a surface. Place the empty basin next to your child. Lubricate the top 2 inches of the tip of the catheter and insert it into the rectum. Gently push the catheter so it follows the curves of the colon. Insert the catheter approximately 4 to 6 inches. Pause for a moment to allow any stool or gas to drain out the catheter into the empty small basin. Connect the syringe to the catheter and inject the 10 to 20 milliliters of saline. Disconnect the syringe and let the saline and any stool drain into the empty basin. Advance the catheter about 1 inch and repeat the process until the discarded fluid is clear. Do not advance the catheter further than the wide divider port. It is important between each injection that fluid drains into the basin. If the amount of saline you inject into the rectum is more than the amount of fluid that returns to the basin, then there is extra fluid in the rectum. To drain the extra fluid, try moving the catheter in and out while twisting. If fluid still does not come out, then the catheter may be clogged. Pull out the catheter and flush with saline into the basin before reinserting. If you think there is still fluid in the colon, you can reattach the syringe to the catheter and very gently pull back on the syringe to draw out the fluid. Do not pull back on the syringe if you feel any resistance. It's important to record the amount of saline injected into the rectum and the amount of fluid that comes out. In a good rectal irrigation, the amount that comes out is larger than what went in. Once the drained fluid is clear, remove the catheter from the rectum and wash your supplies with soap and water, then set out to dry. The supplies are reusable.
Okay. Now let's talk about the pros and the cons. The pros. After surgery, most children are able to pass stool through the anus. Most children with Hirschsprung disease gain weight and growth and thrive after surgery. Rarely, a child may need a second pull through surgery. In the cons, the possible complications that may improve with time include diarrhea, leaking stool, delays in toilet training. Children also continue to be at risk of developing bowel infection, the enterocolitis, after surgery, especially in the first year. The issue applied in Ecuador. There have been 41 cases with Hirschsprung disease and 41 controlled from the Baca Ortiz Pediatric Hospital in Quito and the Machachi Hospital this year. In the conclusion, we have that Hirschsprung disease is a common cause of neonatal bowel obstruction. Neonat who become symptomatic during the first few days of life typically present with failure to pass meconium, abdominal distension, vomiting, and other signs of intestinal obstruction. Most can be treated non-operatively with gastric drainages and rectal irrigation while awaiting the results of the contrast enema and suction rectal biopsy. Rarely, surgery will be required when the obstruction does not improve. Thank you.